Yes, so Dr. Victor, we have recording. We'll just provide you with the recordings of previous sessions. You can just look for that, right? So we are about to start our session. Okay, can you just tell me, Dr. Gyanchi, how much time is left in the our? I just forgot how much time is left in your break. Well, yes, Dr. Muskan. When are we going to start the session? I just forgot the time. Shall we
Five
start it?
minutes. Yes,
5 minutes.
doctor.
Okay,
Okay,
let's.
let's start.
Okay, let's wait. We can start now. Okay, so we are just waiting for the participant. So let's start for. Okay, after 5 minutes, right? Hello, can you guys hear me? Hello, hello. Can you guys hear me? Hello,
Yes, we
Yes,
can.
doctor.
Yes.
hello.
Yes, we can hear you.
Okay, so let's start our today's session. So let me first of all share my screen. Okay, are you guys able to see my screen? Hello.
Yes, yes, yes.
Oh,
Yes.
okay, perfect. Right. So today we are going to start with our new topic, new module, that is red blood cells. Right. So the first topic which we are going to discuss is anemia. But before going to that, can you just tell me different lineages which we discussed? Like we discussed, we have CD34 hematopoietic stem cell. We have two lineages, that is lymphoid lineage, and we have myeloid lineage. Right. Okay, so I want you to tell me some of the cells or some of the components of myeloid lineage. Yes, anyone who can just tell me, please. Okay, yes, you can just open your mic. You can just tell me. Yes, Dr. Huda, what do you guess?
We for myeloid stem cell, we have erythropoiesis producing the erythroblast, and we have thrombopoiesis leading to megakaryoblast, granulocytopoiesis leading to different myeloblasts, and monocytopoiesis including monoblasts.
Okay, perfect. So we have erythroblast, that is red blood cells are going to arise from that. We have megakaryocyte or platelets are going to be arising from that. And we have granulocytes. In granulocytes, we have basophils, eosinophils, and we have then, yes, neutrophils, right? Okay. Then we have, like, as Dr. just told us, we have monocytes, and monocytes are going to give rise to your macrophages, right? So today we'll be like discussing about the erythroblast or red blood cells, right? So can you guys just tell me that what is anemia? What do you know about anemia? What do you think? What is anemia?
Decrease in the RBC.
Okay, perfect. Whenever we have decrease in RBC, basically we use a term for that, that is anemia, right? For example, if we have an individual, right, he's having anemia or decreased red blood cells. Normally we discuss what is the main goal of red blood cell. Red blood cells have hemoglobin. We discussed that, right? And what's the goal or what's the role of hemoglobin? We discussed that hemoglobin basically carries your oxygen, right, to different tissues. Is that right?
Yes,
Hello?
right.
Okay, so for example, if we have an individual who have like less red blood cells or we have anemia, right? So it means that his red blood cells, now he have like less number of red blood cells. Now it means that there would be problem in delivering oxygen to different tissues, right? So all of the clinical features or symptoms which we are going to see in anemia are going to be related with the same concept, that due to anemia, we have red blood cells. As we have less red blood cells, we have less hemoglobin. If we have less hemoglobin, now we have less delivery of oxygen to respected tissues. For example, your kidney, your lungs, for example, your heart, right? So it's going to give us some problems, right? So what would be the clinical symptoms in future, right? Can I say that we are going to have hypoxia if we have less oxygen? Like anemia is going to lead to hypoxia. Can I
Yes,
use just
sir.
use the term hypoxia for that? Perfect. So we have hypoxia, right? So what are the clinical symptoms and signs which are associated with hypoxia? We already know that. So an individual anemia is going to, present with weakness, fatigue, and dyspnea, right? Along with that, he'll be having some lightheadedness and some headaches, right? Okay. For example, if you have an individual who is already having like atherosclerosis, right? For example, if he's having atheroma in his coronary artery, so let's suppose if he's anemic as well, so he can also develop angina, right? We discussed what is angina. Angina we discussed in cardiovascular module, that it's basically a demand and supply mismatch. You have a UWorld MCQ on that, right? So it was basically a demand and supply mismatch, right? So if either you have more, for example, if your heart is using more oxygen, but the amount of oxygen which is provided to your heart is less, it's going to be experiencing an ischemic pain, right? Angina basically is an ischemic pain. We discussed that, right? Hello? So for example, we have a condition in which we have an individual, 80% of his coronary arteries are occluded with atheroma. And again, for example, like an unfortunate event, he develops anemia, right? So I would say that his oxygen delivery is less, although he's having atheroma here, right? And again, you are now delivering less oxygen to the heart, right? This is your heart. So can I say that he can develop demand and supply mismatch? Can I say that?
Yes.
Okay, if he developed demand and supply mismatch, so can I say that he's going to experience an ischemic pain, which is known as angina, right?
Yes.
So he's going to experience angina. Perfect, right? Okay, so can you just tell me about normal hemoglobin concentration in male and female? I think that's like so easy. So let me, okay, please raise your hand, those who want to answer my question. Okay, Dr. Muskan, yes, what do you think?
Doctor, in the male it is 13.5 to 17.5, and in female it is 12 to 16 gram per deciliter.
Okay, 13.5. Let me just write it down. Gram per deciliter. And in female, it's
12
yes.
to 16. 12.
Okay, perfect. 12 or 12.5 grams per deciliter, right? Okay, so basically we are going to divide anemia on, like, we have several classification of anemia, right? So for example, this is your anemia. So basically we classified anemia into three categories, right? So we have microcytic anemia, we have macrocytic anemia, and we have normocytic anemia, right? The idea is really simple. What is micro? As the name indicates. Can I say that the name micro is just telling me that you are going to have anemia, that is red blood cells. But the remaining red blood cells which are present in your body are going to be small, as the name is telling me micro. Can I say that? Can I assume that from this name?
Yes.
Okay, so let me just write it down. You're going to have small red blood cells, right? In macro stands for big. So can I say that we are going to have anemia, as it's like a type of anemia, right? But in that anemia, the remaining red blood cells are going to be big, because the name is just telling me it's going to be macro, right? Big. Can I say that?
Yes.
Yes.
Okay.
Yes.
In the third example, we have normocytic anemia. Normo, it means normal, right? So although we are going to have anemia, but the size of your red blood cells are going to be normal. Can I say that?
Yes.
Perfect. So let's discuss microcytic anemia in a little bit detail, right? Microcytic, right? So there are some causes of microcytic anemia, and students, are it's very difficult for them to memorize. And believe me, I'm going to make this classification so simple, right? With some simple and some basic concepts. So, Dr. Kinana, can you just tell me that you have your red blood cells, right? You have your red blood cell. Can you just tell me that red blood cell, you have hemoglobin in red blood cell? Am I right?
Yes.
Okay, perfect. Okay, can you just tell me that how you do your hemoglobin forms? You have your heme and globin, right?
Yes.
Heme plus globin, right? Okay, let's further divide it. How is heme formed? We know that basically it's made up of iron plus, yes, Dr. Kenana, protoporphyrins, right?
Yes, correct.
Perfect. And the globins are basically protein chains. Can you just tell me which kind of globin chains do we normally have?
Alpha and beta.
Okay, alpha and beta. Perfect. So how do we classify microcytic anemia? The idea is really simple. Let me just write down a story here, right? So here, it's your story session now, right? Okay. So the story which you guys have to remember, that the idea is really simple, right? For example, if you have red blood cell, right? We discuss inside the red blood cell, we have hemoglobin. Whenever you have any process, any pathological condition which lead to less hemoglobin formation, lead to less hemoglobin formation, would lead to microcytic anemia. Why? The idea is that, for example, we know that hemoglobin is made up of iron. So if we have less iron, can I say that we are going to have less hemoglobin?
Yes.
Yes.
Yes, if you have less iron, it means you will be having less heme and less hemoglobin, right? So if you have less hemoglobin in your red blood cell, what red blood cell is going to do? Red blood cells is going to undergo an extra division. Like, for example, this was your red blood cell, right? And let me just write down, okay, just give me a second. Okay, so for example, if this was your previously your normal red blood cell, for example, if you have this much content of your hemoglobin within the red blood cell, let's suppose now this individual developed iron deficiency. So iron deficiency leads to less heme, leads to less hemoglobin. So now the concentration is now less, right? Like this, here you can see the concentration is less. So what your red blood cell is going to do? Red blood cell is going to undergo an extra division in order to compensate for the remaining hemoglobin, like in order to like feel itself that yes, I'm full now, right? I have sufficient hemoglobin, right? It would just do certain things. That is an extra division in order to compensate for the less hemoglobin present within the red blood cell. Is it right? Hello?
Yes, right. Correct.
Perfect, right? So let me just write it down. Okay, so I can say iron deficiency can lead to microcytic anemia. Why? Because if you have iron deficiency, it would lead to less heme, less hemoglobin, less content within the red blood cell. So the red blood cell is going to compensate in a way that it's going to undergo an extra division, which is going to lead to microcytic anemia. And the hallmark for microcytic anemia, whenever the mean corpuscular volume is, yes, how much?
Less
Less
than
than
8.
Less than
80.
70.
80, it's going to be coming under the category of microcytic anemia. What is mean corpuscular volume? As the name indicates, the volume within the corpuscle, right? Corpuscle is a term used for a single red blood cell, right? So if the mean corpuscular volume, or I can say average volume within the red blood cells. We know that normally the volume of red blood cell is occupied by your hemoglobin, right? So whenever this volume gets less than 80, we are going to term it as microcytic anemia. So can I say that iron deficiency can lead to microcytic anemia, or in other words, it will decrease the mean corpuscular volume from 80, is that right? Micrometer
Correct.
per cube, perfect, right? Okay, so let's discuss the other cause of microcytic anemia. We already discussed, right? If you have less hemoglobin, your red blood cell is going to compensate in a way which is going to give you microcytic anemia and extra division. For example, can I say that if you have decreased protoporphyrin, it's going to lead to less heme. Less heme is going to lead to less hemoglobin, and again, your red blood cell would undergo an extra division to compensate the volume present within the red blood cell. So, can I say that, for example, if you have problems with protoporphyrin, it would lead to microcytic anemia? Can I say that?
Yes.
Okay. So, do you guys know any condition like which is disrupting your some processes within the protoporphyrin?
Lead poisoning.
Perfect. Lead poisoning, or I would say you have an anemia which is due to like problem within the protoporphyrin, which comes under the category of microcytic anemia, but we have a special name for that, sideroblastic anemia, right?
Sideroblastic anemia, yes.
Perfect. Sideroblastic anemia. Okay, let's come back to the discussion of iron, right? So we discussed whenever we have iron deficiency, how can we have iron deficiency? We have two mechanisms for that. Either you are just taking less iron. For example, if I'm just taking certain foods which contain less iron, or for example, if I'm just skipping those meals, right, which have less iron, so it would develop to iron deficiency anemia. That's so simple, right? So if I'm consuming less iron, it's going to lead to iron deficiency anemia. But for example, in some condition, I might be having normal iron, right? Okay, normally we know that iron is stored within the macrophages, right? Iron is stored within the macrophages. We'll be discussing that the storage form is basically known as ferritin, right? You guys know that, right? Hello?
Yes, yes.
Okay. So the second condition which we are going to discuss, that although sometimes we might have normal irons, right? But if we require an iron for development of red blood cell, it means that this iron from the store should just come here to your red blood cell, and it should just participate in the formation of hemoglobin, right? For example, if we have some pathology which lead to trapping of iron within the stores, and the iron couldn't leave those stores or those macrophages, can I say that again it's going to lead to iron deficiency, right, for your red blood cell? Now still your red blood cell do not have like enough iron, because we have trapped the iron within the macrophages. There is a process, I'll be just telling you the name of that. So can I say that again it would lead to microcytic anemia, because if you have less iron available for your red blood cells, you have less heme, you have less hemoglobin, which is going to lead to an extra division, microcytic anemia. Can I say that?
Yes.
Yes, sir.
Perfect. So what's the name
Yeah.
of that condition? What's the name of that condition?
It's
Which?
the chronic disease.
Anemia of chronic disease.
Perfect. Anemia of chronic disease. You're going to have a ton of MCQs, right? So till now we discussed whenever we have less iron, it's going to lead to microcytic anemia. If we have problems with protoporphyrin, that we discussed sideroblastic anemia, we'll be discussing it in detail. On besides that, we discuss iron deficiency and anemia of chronic disease, which lead to decreased iron. So the concept is same. Okay. For example, if you have problems with alpha and beta chain, again the globin is going to be less. If the globin is less, again hemoglobin is going to be less. So the story is same. Again, your red blood cell is going to undergo an extra division. Can I say that?
Correct.
Perfect. So again, can I say that it would just lead to a microcytic anemia, extra division? Okay, what are the conditions associated with problems with alpha and beta globin or chain?
Thalassemia.
Perfect. So based on this concept, I bet that each and everyone should know the causes of microcytic anemia, because it's like very difficult for the students to remember, right? So you have a simple and a single concept, hemoglobin, right? Less hemoglobin, having an extra division. So let's discuss these causes in a little bit detail, right? So let's discuss our first topic of today, that is, okay, just give me a second. Okay. So our first topic which we are going to discuss is iron deficiency anemia, right? Hello, can you guys hear me?
Yes, doctor.
Okay. We have, okay, what I don't, okay, perfect. We have iron deficiency anemia. Is that right? Okay. So the idea is really simple. If we have less iron, it means, yes, we have less heme. It means we have less hemoglobin. It means we have less. Yes. What do you guys think? We have an extra division, right?
Yes.
In order to compensate for the remaining content of red blood cells, and it would lead to microcytic anemia. And the mean corpuscular volume is going to be less than 80. We already discussed that. Is that right? Okay. So let's just continue this discussion a little bit further. Let's discuss how do iron get absorbed on the first, right? So we have like a lot of pathologies associated with those transporters as well. We'll be discussing that in GIT module, that is hemochromatosis, right? But before that, we should know the normal, process or the normal steps which involves in, reabsorption of your iron. So for that, Dr. Kenana is going to tell us that inside our gut, which part is responsible for reabsorption of your iron? Okay, enterocytes, perfect. Specifically your duodenum, right?
Yes.
Okay, perfect. Okay, so for example, if these are your enterocytes, right? Let me draw the picture of your enterocyte, right? For example, these are your enterocyte. So what happens? We have a specific transporter present in the lumen. Can you guys just tell me the name of that? Yes, Dr.
DMT1.
Muskan. Perfect. DMT1, right? Or also known as ferroportin, right? So DMT1, right? So here I'm going to tell you an interesting story, and all of your labs are going to be, based on this story. So please just keep focused, right? So what DMT1 is going to do is going to take iron from your lumen, right? And it's going to put it inside your blood. Is that right? Hello?
Yes, right.
Okay. We discussed that this iron ultimately is going to be stored where? In the macrophages. Macrophages of your liver and your bone marrow, right? Hello? Okay, perfect. So if we have reabsorbed our iron from the duodenum, it is now present in the blood. So we want someone to carry it to their stores, right? We need some cars so that iron can sit inside those cars and it can reach its destination. That is macrophages of your liver and your bone marrow. Is that right? So what are the name of those cars or those transporters which helps your iron to go into your macrophages? They are known as, okay, they are
Transferrin.
perfect. They are transferrin, right? So, and the idea is very simple. They are transferring your iron from the blood into your macrophages of your liver and bone marrow. The idea is so simple. Is that right?
Yes, right.
Okay, perfect, right? So let's discuss some lab measurement of iron status, right? Some lab measurement. And we already discussed, like Dr. Mahin just told you, that in hematology, you should be concerned about the lab findings. You should know each and everything about your lab findings. So let's discuss some lab measurements, right? So till now we discussed that we have iron present inside our blood, right? We have iron. Okay, where do we get iron? Inside the blood, right? We discuss. Then we can also have iron sitting on those cars, right? Sitting in the cars. That is in the transfer, right? Hello? We can also have iron present at their stores, right? The macrophages. Is it right? Hello?
Yes, doctor, right.
Okay, perfect.
Yes.
Yes.
Perfect. So remember an important point which you guys should remember. For example, okay, so this is basically known as ferritin stores, right? We already know that. Ferritin stores. Okay. For example, whenever these stores are less, right? Like you can just consider it as a factory of iron, right? It's a factory. Iron ultimately is going to go into the bone marrow in order to make your red blood cells. We already know that. So the macrophages are basically the factory of iron where iron is being provided to your red blood cell for hemoglobin formation. Is that right? And ultimately for oxygen transport. Is it clear?
Yes.
So we can just consider the iron as, workers, right? Okay, so we know that these workers are first of all taken from the lumen, they sit in the cars, and then they are just taken into the factory, and from the factory they go into the bones where they can form red blood cells, right? Or hemoglobin. For example, if inside the factory, inside the ferritin or the factory store, if we have less iron or if we have less workers, so what this factory is going to do, it's going to increase, it's going to tell your body or your liver to increase the cars, right? To increase the cars, bring me some more, workers, because I need them, right? Right. For example, the red blood cells are going to tell them that please give me my iron, but the factory do not have iron. What factory would do? It would just tell your liver to just please make some more cars, because cars come from your liver, right? Hello?
Yes.
Yes.
So can I say that whenever the ferritin goes down, the transferrin increases? Or in other words, can I say whenever we have less workers in the factory, so the factory is going to tell the liver to make more cars, to bring me more workers? Can I say that?
Yes.
Correct.
Yeah.
Perfect. And on the other hand, if the factory is already having sufficient amount of workers, so what the factory is going to tell your liver, your car maker factory, it's going to tell that don't make cars, we don't need, because we already have workers. So till now we develop a concept that whenever the ferritin goes down, okay, sorry for my spellings, ferritin goes down, what happens? Transferrin or the cars go up. On the other hand, whenever the ferritin go up, the transferrin goes down. Can I say that?
Yes.
Okay, perfect. But an important point which you guys should remember, right? As we have a lot of cars here, like for example, if we have 10 cars, right? 10 cars for the workers or 10 cars for the irons, right? Remember, normally, all of these cars aren't, loaded with the iron. Like for example, if I have 10 cars, right? Let me just draw 10 cars, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. For example, if I have these 10 cars. So normally the workers only sit in 7 cars. The 3 cars which are revolving or moving inside your blood are always empty. So 1, 2, 3, 4, okay, 5, 6, 7. Okay. Hello? Can you guys hear me?
Yes. Yes.
Okay. No. Okay, I was wrong. Normally you have 3 cars filled with iron and 7 cars empty. Really sorry for my statement, right? I'm just, taking away my statement, right? So normally if we have 10 cars, so only 3 cars, inside the 3 cars, you are going to have iron. So can I say that normally, okay, so let's just take a percentage out of that. So can I say that we have, like, if we have 100 cars, so we are going to have 30 cars filled with iron, right? So we normally, okay, just please give me a second. Okay, so can I say that in 30% of the cars, we have workers sitting, right? And 70% of the cars are empty. Can I say that?
Yes.
Hello? Normally inside our body, right? Okay.
Yeah.
So the idea here is that it's a percentage saturation. What is percentage saturation? Or in other words, can I say that 3 or 30% of your cars are saturated with your iron, right? But 70% of the cars are unsaturated or desaturated. Can I say that? So can I say that the percentage saturation of the cars or the percentage saturation of transferrin, right? Cars were your indicative feature of transferrin, right? Is normally 30 to 33%. Can I say that?
Yes.
Okay. For example, let's suppose we discussed whenever the ferritin goes down, the cars are going to increase, right? Hello?
Yes.
And
Yes,
whenever the ferritin go up, the cars are going to decrease. But it also have effect on the percentage saturation as well. Like for example, if the ferritin goes down, right? So the transferrin would go up, but along with that, the percentage saturation or the number of workers sitting in the cars would also, yes, what would happen to that?
decrease.
Yes, what do you think? Would it decrease or increase?
Increase.
If ferritin is low, yes.
Okay, if transferrin is low. Okay,
Transferrin is low.
It's
Okay,
the
let's just take an
Then it
example of
will
ferritin, right? So it's a question for you guys, right? And you guys are also going to explain it as well. For example, my question is ferritin is less and transferrin is more. What do you think will happen to the percentage saturation?
it should decrease.
It decreases.
Okay, perfect. It would decreases. The idea is that whenever the ferritin go down, it means the iron stores go down, right? We have less iron. So if we have less iron, the cars are more, but the iron is less, right? So there are less workers sitting in the cars, right? Did you guys get that? We are going to discuss some of the pathologies, and then this idea is going to be really clear. But till now, you should know what is percentage saturation. That's simple, right? So let's discuss iron deficiency anemia. So how can we get iron deficiency anemia? I think the discussion further is going to be really easy. So please raise your hands, those who want to answer. Okay, okay. What are yes iron deficiency anemia? What are the dietary causes of iron deficiency anemia? Yes. So please raise. Okay, Dr. Hazira, what do you think? Can you just please quickly tell us? Now we are going to have a discussion session, right? I won't use any whiteboard. You guys
Due
are
to
going to tell me.
decreased iron intake or iron absorption.
Okay, perfect. So in children, right, we can have, like, for example, those who are just taking less supplements which contain iron. For example, in the meat, we have iron in the heme form, right? Hello?
Yes.
Okay, like for example, nutrition deficiency can lead to iron deficiency. For example, we can also have like other problems. For example, the hookworms and ankylostoma. It can just suck all of the blood, and which in turn could decrease the iron, which can also lead to iron deficiency anemia, right? Okay, so let's discuss some lab findings. For example, if you have an individual, he's just taking less iron, right? So those who want to answer, those who want to participate, please raise your hand because it's a kind of review, right? So Dr. Muskan, let's suppose if I have iron deficiency. So can you just tell me what will happen to ferritin stores if you
It
have less
should
iron?
decrease.
Okay,
Decrease.
perfect. If the ferritin decreases, what will happen to the cars or transferrin?
Increase.
Perfect. Okay, what will happen to the serum iron, overall iron present in the serum?
Serum iron, it should be normal, I think. Or
Okay,
decrease.
serum
Decrease.
decrease. You have decreased serum iron because on the first place you aren't taking the iron, right? So in the serum you will be having
Yes.
less iron. Okay, what
Yes.
happens to percentage saturation if you have less iron? You have no
Also,
one to
it
sit in the
decrease.
cars. You
Decrease.
have no one to sit in the cars. If you do not have anyone to sit in the cars would be
Empty
you know
more. Decrease.
okay, yeah. Okay, so let's discuss. So these were the lab findings which we discussed. Okay, another thing, let me just tell you an interesting thing. We discussed that iron ultimately is going to bind with protoporphyrin, right?
Yes, right.
Okay. For example, if we have less iron or iron deficiency, what do you think will happen to the level of free protoporphyrin?
It should increase.
Yes, it would increase. Perfect. Because if you do not have iron, so how would it form bond? So the free iron is going to be increased because it loves to bind with iron, right? Okay, so let's discuss our last topic for today, and then Dr. Taha is going to continue the session. That is anemia of chronic disease. We already discussed some of the details of anemia of chronic disease. So I just, we let the foundation, we let the concepts. So let me just ask you some questions. We already know what is iron deficiency, anemia of chronic disease. We know the causes. So Dr. Victor is going to tell us why on the first place do we have anemia of chronic disease. So till now we discussed what is anemia of chronic disease. We discussed that it's basically, iron. We discussed it's basically iron staying within the stores, right? We discussed that. Hello?
Yes, sir.
Okay. So my question is, what led to this process? What led the iron to stay inside the store and the iron coming out? What's the main pathology behind it? What's the main cause behind that?
Hepcidin?
Okay. Let's just make it a little bit more easy. Can I say that it's due to chronic inflammation?
Yes.
Okay, chronic inflammation. So what happened in chronic inflammation, we discussed that our liver is going to produce certain substances, that is acute phase reactants, right? And one of the acute phase reactant is your hepcidin, right?
Yes.
Yes.
Okay, so what hepcidin would tell your stores? That do not let iron to come out. to not let iron to come out. It's a normal process. If it's a normal process, can I say that it's a beneficial process?
Yeah, it's a productive
It's a
process.
protect. So how is it a protective process? The idea is simple. For example, in chronic inflammation, for example, if you have bacterial, inflammation, if you have bacteria, if you have bugs present within your body, so normally your bacteria or bugs love to eat iron. They survive on iron, right? So what hepcidin in chronic inflammation is going to do? It's going to do a positive mechanism. It's a good mechanism for us. It's going to tell your stores not to release iron, because we have bacteria, and bacteria love, they survive on iron, right? So what happens in this process, we just have a big loss on the other hand, and that loss is less iron, less heme, less hemoglobin, and extra division, microcytic anemia. Is it right?
Yes, right.
Okay. So let's discuss some of the chronic inflammatory diseases. We already know that, or some autoimmune diseases, they are chronic inflammatory disease, right? So they remain for chronic period or chronic duration of time. So let's discuss some lab findings. In this case, if I'm not letting iron to come out, so what happened to ferritin store?
Increase.
Perfect. Ferritin stores would increase. If you have a lot of workers in the company, in the industry, what happens to the cars? Transferring.
Decrease. Decrease.
Okay, decrease. Perfect. Okay, what would happen to percentage saturation?
Increase.
Increase.
Okay, so the percentage.
I think decrease because
Decrease.
What
the
will happen to percentage saturation?
decrease.
Decrease. Percentage saturation is going to decrease,
Because
right? Because
transparent.
all of the iron is staying within the stores, right?
Yeah.
Okay, perfect. Okay. What will happen to free erythrocyte protoporphyrin? What will happen to protoporphyrin?
It will
Increase.
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 Increase. Perfect. And what is the treatment? The idea is very simple. If you have some chronic inflammation, just treat that. Everything is going to be fixed. Simple. Is that clear?
Yes.
Okay, so these were the two topics, and we just spent some time, because like these are going to be the basics for your red blood cells module. And believe me, the white blood cells, like most of students are like very afraid of the lymphomas and things like that. We are going to make that super easy as well, right? So hope so you guys enjoyed the lecture, and
Sir,
as I'm just tired. Yes, please.
can you rediscuss the thing that enterocyte wali diagram?
Okay, so we'll just discuss that. So we have enterocytes, that is duodenum. Iron is going to be reabsorbed by a transporter, DMT1. Then this iron is going to be loaded into the factory cars, that transferrin. Transferrin is going to take these workers into the factories. What are the factories? Ferritin, right? And ferritin in turn is going to give the workers to your red blood cells in order to make hemoglobin. Is that clear?
Yes, sir. Thank you.
Okay, let me just give you an entire overview, then I should leave because I'm, like a little bit tired. Sorry for that. So we have CD34, we have myeloid lineage, we have erythroblast. What is anemia? Decreased red blood cell. Less red blood cell, less hemoglobin, less oxygen delivery. It means hypoxia. Hypoxia, demand supply mismatch. It can cause angina. What is anemia? Micro, macro, normal. Micro for small red blood cell, macro for big red blood cell, normal for normal red blood cell. How do we get microcytic anemia? Anything which disrupt in the formation of hemoglobin, right? For example, hemoglobin is formed from heme and globin, heme from iron protoporphyrin, right? So if you have less iron, we have less hemoglobin, red blood cell is going to undergo an extra division. Similarly, if you have thalassemia, again, the same story, right? Microcytic anemia. So we discussed the processes, we discussed the iron transformation, we discussed ferritin, transferrin, percentage saturation. Normally 33, like 30 cars within the 100 cars are going to be filled, which is percentage saturation, which is 30% to 33%, right? So anemia of chronic disease, hepcidin, chronic inflammation would lead to hepcidin. Hepcidin will sequester or catch all of the iron in the ferritin stores. And as a result of that, your red blood cell won't be able to get iron from the factories, which would lead to less heme, less globin, less hemoglobin, extra division of red blood cell, microcytic anemia. With that, we ended our today's discussion. Hope so you guys enjoyed. Okay, so if you have any questions, so I'll just please tell you to ask tomorrow related to this topic. Really sorry, but before that, can you guys just please give me a feedback so that we can, if we have like some feedback, are you guys enjoying the format? Are you guys enjoying the sessions? And are you guys enjoying the template that we have, kept for the upcoming preparation? Hello. Yes, you can please turn on your mic if you guys have any feedback or anything. So it would be highly appreciated. Yes, Dr. Raj, what do you think? Hello?
Yes,
Dr.
you're enjoying the process. Thank you so much for your sacrifice and your help. We really appreciate you, sir. Thank you.
Thank you so much. Thank you so much for staying here and making this journey like even interesting for us as well. Okay, don't leave the meeting, right? Dr. Taha is soon going to join for your UL discussion. Is that right?
Yes.
Okay. Yes. Once let's wait for Dr. Taha, and that time we'll just have a little bit gossip, right? So what do you guys think? Do you guys have any suggestions for further improvement?
Sir, I just have a question. When will we be getting the UWorld IDs for the red blood cells?
Yes. So right after the session, we are going to share that, right?
Okay, thank you.